Hello, this is Bob Browner, and this is basically a short recording of kind of what I've learned in 15 years of quality improvement that'll hopefully help the clinics that I work with avoid some mistakes of the past and do even better. So over the last 17 or 15 years, I've spent about 7 years in the faculty of a residency program, 9 years working with community projects across Lincoln and the state, and started two ACOs. And so we're working with dozens of clinics on this. And so this is sort of a list of lessons of what I've learned over the last 15 years. So some things to get right when you do your quality room, I really put it in three buckets. One is focus on feeding the cow, not weighing the cow. Second is to roll them out in buckets, and three is to get creative and a few extras at the end. So started on the feeding the cow versus weighing a cow, and this is the Middle Eastern proverb. Hopefully you've seen it before. You can't fatten a cow by weighing it. I kind of like these proverbs because I grew up raising cattle with my family, and this is me at the Cheyenne County Fair back when I was a kid. And so the distinction I try to make for clinics is the difference between feeding the cow and weighing the cow. Feeding the cow is what you do to take good care of your patients. Weighing the cow, that's, however they're measuring quality improvement from the insurance perspective at the end of the year. And the biggest mistake I see is people looking at how the insurance company defines it and working backwards instead of first starting with what's good care of our patients, working on that. And then if you do that really well, you'll be just fine at the end of the year. And one of the things I like, there's a quality improvement model put together by David Scrace. He's an internist and geriatrician. This was published in the Annals of Family Medicine a year or so ago, and I really like the way he's put together his model. You've probably seen things like PDSA cycle and stuff like this. This is very similar, but he has a couple things that I think are really important. Number one is start with what's most important. What do you think is the best way to take care of patients? That's how you should define everything. Start there first, and then start working forward. Sure, you got to collect some data and see where you're at. Step three I really like is argue about the data, because the first time you pull that data, it's going to be wrong, and it's never going to be perfect. And so just acknowledge it's not perfect, but it can be improved and it can be acted upon, and we can make our patients healthier if we keep doing this the right way over time. So first, define your measures based on all of your patients. Don't just use one narrow age range. Don't just use one insurer's definition, and don't use it based on a calendar year report. By a calendar report, I mean some of the programs out there, so UDS HRSA that FQHCs follow, and some electronic record programs and ECQMs, they only look at the calendar year. And the problem with looking at a calendar year report is if you started in January here and now it's March and you run a report, it's only going to look at the patients that came to your clinic in this little 3-month window. Well, that little 3-month window isn't representative of your patients, and if you're running a quality report, the most important thing is the people who didn't get whatever you're defining as quality. They won't be in your report because they haven't been into your clinic yet. And so if you're only looking at the calendar year, you're missing all these patients that you really need to be reaching out to aren't going to be in this report. So yes, the calendar year report works for year-end reporting. It does not work for taking care of patients. And so most clinics are using a rolling 24 months, where it's basically looking at all the patients that have been in our clinic for the last 24 months. That's still not ideal. The ideal is all of your active patients. The problem is most clinics don't have an active system to take or deactivate patients who've either died or moved to Arizona or whatever. And so if you define it more than 24 months, you end up getting a lot of patients that aren't really your patients anymore, unless you have a good system. Some clinics do have a pretty good system, so most people are defaulting to a rolling 24 months. So do that. Don't use a calendar year report. The other thing is roll out your quality initiatives in buckets and make it a fun competition. So by buckets, sometimes you do things similarly at the same time and there are similar metrics, so use the same thing. So we're starting across the country and even locally and in statewide, moving toward a core set of measures that most everybody is looking at. They cross insurers, and they've come together partly because of the evidence showing that they're good, two, that they're just needed, and three, by doing these together, that alignment actually makes them better. And so it's good to put everything together, hopefully, so you're doing the same thing for all your patients, not unique things for each patient. So the three buckets we're aligning around to are what I call cancer bucket, the chronic and cardiovascular disease bucket, and don't forget the pregnant women and children. So cancer bucket, most of your measures are using breast, cervical, colon cancer, and I would throw HPV vaccination in there also. So if you're focused on cancer, the reason to focus on cancer is one of our top two leading causes of death, and of course our general goal is to not have patients die. So These are things that are probably going to be done, and they're often done at the same time. So they're usually done during wellness visits of some sort. So putting these into your clinic workflows as a group, when a woman comes in who's 53 years old, you should get breast, cervical, and colonoscopy dressed all at the same visit. For children, of course, we really want to get our adolescents vaccinated HPV, because we could eliminate cervical cancer and half of throat cancer from Nebraska in a generation if we did a good job with this. The next big bucket is what I'd call chronic disease and cardiovascular disease. They all tend to work in a herd. They all can be addressed during your chronic disease follow-up. So if you're a diabetic, you should be looking at A1C, exams, nephropathy, foot, blood pressure, lipids, all together. That's part of good diabetes care. And of course, non-diabetics, blood pressure and lipids are important, but blood pressure probably being the most important one. These are, again, this is the other top causes of death. Cancer's one, this is the other. Also, from a cost standpoint, this is an ACO cost report showing the source of costs for this whole population. The two big daddies are diabetes and high blood pressure, so why not focus both? They go together, they have the same type of risk factors, same lifestyle. Meds are a little different, of course, but other than that, they tend to go together, so work on them together at those chronic follow-ups. Also, there's some good evidence. This is a Healthy San Diego County initiative where they got all of or most of the clinics in the county to work on blood pressure, A1C, and lipids, and they were able to show a 20% reduction in heart attacks with an $86 million savings for the county. So getting everybody aligned and doing this together, I mean, it works for the entire community. It doesn't just make your patients healthier. It literally can affect health at a county level and save money. And the last bucket is don't forget the pregnant women and children. And so some of our ACO and medical home contracts are using different combinations of these measures. The Blue Cross ACO right now has HPV vaccination as an adolescent vaccination measure. Other folks are looking at various things. Medicaid is probably going to be releasing some things this year, and there's an aligned group that also is working on this. We've worked on prenatal risk assessment in the past as well, and I think that's still something that needs to be done. With some latest stuff coming out from ACOG, there's going to be probably a bigger focus on postpartum visits and postpartum depression screening in the future. Half of perinatal deaths happen postpartum, and 1 in 7 women have some degree of postpartum depression. So I think you're going to see more and more of a focus on this in the future than the physicians. And so sometimes turning some things, especially vaccination projects, over to the CMAs and nurses will often do it better if they've got the appropriate standing orders in place. Clinics, sometimes if they make it a fun competition, even sometimes the goofier the better. I've seen people do horse races, team mascots. Doctors and nurses are all really competitive by nature, but that can be channeled for good. The other thing is to make it a community effort. Biggest thing I see over and over again is not staffing appropriately for this. And so one way to look at this is consider the staff you need for ongoing operations and the concept of having enough slack time in the system. My management professor at Johns Hopkins was a big proponent of that. He said one of the biggest mistakes some managers make is they make things too efficient. They engineer all the slack time down. And without slack time, you don't have the time to be creative and fix things. It's also a problem in clinics because our work load varies so much. Flu season, people are sick, things like that. So the true workload isn't a stable workload. It's more of an up and down like this, where the work varies sometimes from day to day. You need enough slack time in these times to make up for the catch-up time when it's flu season or somebody's out sick and suddenly everybody's in the hamster wheel and everything's behind. You need enough of this time to make up for some of this time. And I think what happens, and pretty much this is rampant across the country, is we have insufficient slack time to make up for the catch-up time, and everybody's on a hamster wheel, burnout, crabby, grouchy. And when that happens, people do not provide the best care. And so we need to make sure that our systems have enough slack time and staffing so we don't end up there. The other thing is protecting time. So one way to think of things is that there's ongoing operations, but the care coordinator role, most clinics, if it's a decent sized clinic, that should be a full-time position actually, who's most of the time focusing on the care coordination work and not rooming patients, doing the day-to-day getting things done today stuff. Part-time is another role, and oftentimes this is that lead clinician that has some designated time throughout the week, usually an hour to 3 hours, depending on how big the clinic is. A 14-doc clinic, that might be a half a day job. 3 to 4-doc clinic, maybe it's an hour a week job, but that physician needs some time to get some of this stuff done. Ideally, what the staffing should look like is you're seeing patients with your ongoing operations with your staff. Some of your day-to-day nurses and everybody else should have some time to catch up and work on these things you're trying to get them to do. The lead physician should have a part-time gig where they actually have some time to work and go to the meetings and plan this stuff. And your care coordinator should have enough time so they're protected time. So I've seen a clinic, for example, where they're understaffed and the care coordinator kept getting pulled into doing vaccinations, rooming patients, and she was actually trying to do some of her stuff in the evenings after her kids were asleep, and that's just not a good situation. It leads to burnout. Sure, there's some times where the care coordinator gets pulled into that because somebody's sick or it's flu season or something like that, but the care coordinator needs time to do those post-discharge follow-ups, to pull the gaps in care reports, to do things like that. So you need to staff your clinic appropriately. The other thing, like I say, do as a competition. Have people, we like as physicians and nurses to be compared and see if who can do better. And so here's a clinic level view of a bunch of clinics in our region that we're working on colon cancer screening. And when people start doing really well, they really get into this. And so if you can use that for a good mentality and get people to say, hey, we want to be over here. And you can do that at the clinic level too, where instead of this is clinic-sized bubbles, each physician or team might have their own levels too and try to compete with each other. And also make it a community effort because it can work. So we've been having a colon cancer screening project in Lincoln, Nebraska for the last 3 years running now. We do have the best colon cancer screening rates in the state because all the clinics have banded together to try to do this at the same time. We've even worked on some things to get some people with low income, get some grant funded and other sources of funding to get their colonoscopies when they couldn't afford it. So these things can be done at the community level to make your tighter community healthier. The other thing is get creative and learn from others, and there's many ways to do it. And so one of the things that I've seen over and over again is that every clinic is just different. So some clinics say, give me the magic workflow, and I can't do that because every clinic is different. Every clinic has different staff with different skills, different interventions that may try, and they may work better in one clinic versus another. So for example, in a low-income clinic, sending letters in the mail won't work because low-income people tend to have unstable addresses, and so a lot of those letters would come back. So text message or some other thing would probably be better in a low-income environment. Whereas in a wealthy environment with a stable population base, maybe that would be more effective. And so sometimes your situation will change things. So it's your job as a clinic. You know your clinic better than anybody else. What things would work? What opportunities do you have? What staff? What things can my EHR do? Like I say, the standing orders and rooming workflows are some of the best things you can do for vaccination improvement. And then you will know based on your staff and what you're going to intervene. Your workflow may look a little different than the next person's workflow. The evidence is if you come up with your own, you'll do it better. Other stuff that, just in summary, those are the big buckets, but there's a couple other things that are kind of interesting that you may not think about. Post-discharge medication reconciliation may be one of the biggest things we can do to help our patients to prevent readmissions and complications. Still the number one cause of medical errors is medication errors. Most of the clinics I work with, the care coordinators in their role very quickly see how bad the discharge medications lists are coming from the hospitals. They're just not put in a format that patients can understand. They get confused. There's all the name brands and formulary switches. And so really one of the biggest things you can do after a discharge from a hospital and someone with 3 or more meds is make sure that the meds are reconciled correctly. Another big one is fall risk assessment. I kind of underestimated this one at first, but I think fall risk is getting to be more and more an issue. We know now that lack of physical fitness is the biggest risk factor in Trump smoking, actually. Fall risk assessment tests a patient's mobility, especially as they're getting older in life. And a lot of things go wrong when people can't even do a get up and go test. And so it's one of those threshold things where we could eventually prevent a lot. One person, when an elderly person falls and breaks their hip, about half of them are dead or in the nursing home in 2 years. I have a physician I work with that he calls the annual wellness visit the keep your ass out of the nursing home visit, and I think that's part of that whole mentality, and it might motivate our patients more because the last thing many of us want to lose is our independence, and so fall risk assessment may be important than we realize. The last things we'll finish up with is the social determinants of health. You'll start hearing more and more about this in the future. I was at a conference where someone from a major insurer, they ran all their costs by 2 things, and they looked at 2 social determinants of health that had the biggest difference as far as hospital admissions and costs, and they were food insecurity and loneliness, actually. Well, why would those be the case? Well, food insecurity, it sounds like sort of a fluffy, bleeding heart liberal measure, but what we've found is that food insecurity is a threshold moment. When you get to the point where you don't know where the meals are coming from tomorrow because you don't have stuff in your fridge, that's when everything else goes to hell as well. That's when you can't afford rent. That's when you can't afford your meds. And so they've actually, the AAP and AFP have put together, there's actually a 2-question screening instrument for food insecurity. And if you test positive on this, it tends to be sort of a threshold for when all other things go wrong. That's when people are going to be not compliant with their meds, because when it comes to putting dinner on the table and buying their meds, putting dinner on the table comes first, and it's helpful to know that. The other thing is the loneliness and household size of one. And so many of you may think back, how many of you know an elderly person who dies and then the spouse dies within weeks or months? That happened to my own grandparents last year. Someone in the office, it was just here last year, her parents died within a month of each other. Loneliness makes a big difference. I was a clinic I work with where the physician ran all of his out of control diabetics and found out that more than half were coming from a household side of one. So basically, lack of help, lack of people to help take care of you is a huge marker for things not going well. And it's pretty clear that those people end up have a lot higher healthcare costs. So some things to think about. I'll be out to your clinics for many of you in the near future. I'd love to talk to you about some of these things, and hopefully you'll find this helpful.